For the next session, we have the rehabilitation interventions of spasticity in spinal cord injury. I'd like to invite the chairpersons for this session, Dr. Dibyendu Das, Associate Professor, Department of PMR, Bardhaman Medical College and Hospital, and Dr. Shuparno Ganguly, sir, Director of Neurorehabilitation at Institute of Neurosciences, Kolkata.
The first speaker is Dr. Amit Kumar Ghosh from INK. He is a renowned neuroscience in the city, and he will take on the first about the plasticity in SCI.
Thank you, respected chairpersons. And I like to express my gratitude and thanks to RehabCon organizing committee for inviting me here. It's my privilege and pleasure. Thank you very much. So today's topic is BACLOFEN pump and its indications and intricacies. Ashtaki. So intrathecal BACLOFEN is used for spasticity for various causes. We know already that what spasticity is, so I'm not going too much towards this spectrum of management of spasticity. So I think everybody knows, so I'm not discussing this in detail. Neurosurgical treatments, what is available for spasticities are selective dorsal rhizotomy, neurectomy, myelotomy, cordectomy. But commonly we do two things, BACLOFEN pump and SDR. Selection criteria for severe spasticity is modified Ashworth grade more than 3. It has to be 3 or more than 3. And it has to be refractory to oral medications or intolerable side effects causing pain. Below this is the Ashworth scale, which we follow during assessment of the patient. So potential benefits of ITP therapy, it reduces the spasticity, spasms and pain, facilitates rehabilitation, functional improvements, independence, ease of care, programmability and reversibility. So this is the main advantage of the destructive surgeries and neuromodulation. So basically this is the pharmacological neuromodulation, the BACLOFEN pump. We directly apply drugs into the nerves. So this is called a pharmacological neuromodulation. So programmability and reversibility is the key for this. Before putting the instrument, we have to do a screening test. So in screening test, patient comes one day for a screening. We do lumbar puncture and you give injections. First 25, 50 and then 75 and then 100. So this is very important. If patient improves at least 2 grades, Ashworth grade, by screening test, then only they are the candidate for BACLOFEN pump. So this is the protocol. Day 1, some people starts from 25, but we directly start from 50. 50, day 2, 75, and day 3, 100. But this protocol, it differs institute to institute. Now we do 3 doses in a day, single day. We first give 50 microgram. After lumbar puncture 50, you see for 1 hour, no improvement, then another 75. But it has to be in a controlled environment because patient might develop sometimes cardiorespiratory problem. So there has to be a resuscitation facility. So we do it in a recovery room just adjacent to our operation theater. If patient develops any problem, our anesthesiologist can handle the situation. So clinical response to medication has to be decreased in muscle stone, 1 point at least for spasticity of cerebral origin and 2 points for spasticity of spinal origin. And we have to monitor 30 to 60 minutes after injection. Now pump implantation. This is the device that we are going to put in our body. This is called a Synchromed 2 intrathecal pump made by Medtronic. So this is the device where we can see there is a catheter port where the catheter will attach, catheter access port, suture loop where we fix with the fascia, and reservoir fill port. Through this fill port, in future, we have to refill the pump. And that side, I don't know whether it is visible or not, there is a catheter in the below. There is a catheter. Pointer ache. So here, not visible here. Anyway, pump. So how we implant it? We do lumbar puncture. Insert the 2 needle at mid or upper lumbar space in an oblique paramedian trajectory. Negotiate into the intradural space. Positioning of the catheter tip at levels according to therapeutic indication. Approximately the tip of the intrathecal catheter has to be T1, T2 level with spasticity, quadriplegic spasticity, and T6 to T10 level with spastic diplegia. In the mid-cervical region, if there is generalized dystonia. Subcutaneous tunneling is the next step, subfacial placement of the pump in the anterior abdominal wall, and next coming to programming. Now this is one picture where we can see there we did the lumbar puncture and we did the tunneling. This is the tunnel, this is the end of the tunnel, and this is the tunnel. In the abdomen side, we did a small opening here, subcutaneous pocket in the anterior abdominal wall, and this is the lumbar region. So yeah, that's a video. So in this video, anyway, this is the port before surgery where, yeah, so this is the catheter access port. This is the anterior abdominal wall where we put the impulse generator pump actually. And intraoperatively, we do a fluoroscopy. This is the X-ray which confirms the tip of the catheter. So this is the catheter. So it has to go up to T1 level or T6 level depending on the diplegia or quadriplegia, something like that. And this is the device. It is a bit bigger view. So this is the port, filling port. This is the catheter access port, and this is the catheter. We connect the catheter here. So one end will be here, another end will be into the intradural space. So after that, when procedure is done, programming is the most important part. So how we program it? This is the wireless communicator. So this is the abdomen. So this has to be here. So like that way, our nurse is putting the wireless connector here, and this is the programmer. So this is the programming. Programmer is basically a tab, and there has to be icon. This is that Synchromate 2. So this app has to be there. Click there. This page will open. Connect. Click there. It will be connected. Wireless connection. So this is connecting. After this page will open. And here you have to select how much dose you want to give. What is the 24 hours dose, depending on the clinical effect. And then if you want to give a bolus, then also. So normally in one refill, we fill with 2 ampoules, 20, 20, 40. And it looks like that in a programmer. This is 40. Total content, total drug content. So this is 20, and this is 2 ml is the least content. When there will be used all the drugs, and at 2 it will give the alarm. And this is the daily dose, hourly dose, everything we can decide. We can change the diurnal variation, we can decide the diurnal variation also. That in night, when patient is not working, we can reduce the dose. In daytime, when patient is going to office or doing the work, according to programmer, we can increase the dose. So that we can decide the diurnal dose. We can decide whether bolus is required or not. So alarm, audible alarm. So there are two types of alarms are there: critical alarm, non-critical alarm. So non-critical alarm, one tone, beep. Critical alarm, beep, beep. So non-critical alarm, when low reservoir volume, pump nearing end of service, because this pump has an end of life. Maybe 6 years, 10 years, depending on the uses. And then you have to replace the pump. So this is non-critical alarm, and in some memory error also it can give non-critical alarm. Critical alarm, when reservoir is completely empty or end of service, it will give the alarm. Then we have to change it very urgently. This is the model specifications. And refilling of the baclofen pump, for refilling, patient usually comes to OPD, and we refill in the OPD basis. You just put a butterfly catheter with 40 cc baclofen injection. You can feel it. So it is very simple procedure, but you need a proper trained personnel. You feel and then program it. How much dose you want to give in a day, or you want to increase the dose. So changing from simple continuous dosing mode to flexible dosing mode is possible to treat the predictable variation in daily muscle tone. So there are different modes of programming, modes of giving the baclofen. The maintenance therapy, spasticity of spinal origin of patients, maintenance doses of long-term continuation infusion baclofen intrathecal dose ranges from 12 to 2003 microgram per day. We can increase. Most patients adequately maintained on 300 or 800 micrograms. But again, in the limited experience of daily doses greater than 1000 milligram per day. Spasticity of cerebral origin, most patient maintains 90 to 700. Most patients, but we can go up to 1400 microgram per day. Complications, risk of infection, always any device, any foreign body you put, risk of infection is there. Risk of device malfunction and drug related complications is there. Sudden withdrawal of the baclofen, it abrupt interruption, it can cause severe spasticity, and with that spasticity patient even might have a respiratory arrest or cardiac arrest. And overdose also sometimes can cause a lot of problem as a human error. Suppose people who doesn't know programming, he increased the dose and patient develops seizure, or even they might go into coma. So these are the signs of overdose: drowsiness, lightheadedness, dizziness. These are all respiratory depression, seizure, and ultimately we might lose the patient, loss of consciousness and progressing into the coma. So gradually these are the from little to very severe side effects. Now imaging evaluation, suppose after intrathecal baclofen pump, still patient improved and then again patient deteriorated. Device is not working. So we can assess by X-ray, fluoroscopy, catheter port myelography. So this is the most important investigation. Practically we do it. We put some dye into the port and we do X-ray and see whether dye is reaching in the intrathecal space. If there is any, if dye is not reaching, then the catheter block is there. Catheter is blocked. Or there may be disconnection of the catheter or catheter tear. The drug is not reaching, in somewhere in the abdomen drug is lost. So effect will not be there. Nuclear scintigraphy, it is test, but we don't have it, so practically we can't do it. Thank you very much. Any questions?
Thank you, Amit, for that beautiful presentation.
Neurogenic bladder and spinal cord injury. In spastic bladder, the baclofen pump, the successful rate.
No, sir, no. The bladder is the autonomic function. So bladder will not improve bladder function.
Thank you.
What is your experience? How many cases you have done?
We did around 30.
How they are doing?
Their spasticity, as per spasticity,
How
they are doing good.
how much scale?
But main frustration of the patients remains, they still cannot walk. Because the paraplegia will not improve by this pump. And this is costly. The pump and this whole thing, operative process costs at least 10 lakhs.
Have you done in cases of dystonia, generalized dystonia?
No, I have not done, but only spinal injury we have done. Only spinal injury. So cost is a barrier.
So Amit, just a quick question, or probably I think you'll be able to answer that properly. Two things. One is regarding the cost. We all know that it's costly thing, but is there any insurance schemes where the patients can actually benefit out of that scheme?
Most of our patients, they sometimes comes from West Bengal government scheme. They cover the whole thing.
Yeah.
Last case we did, they covered the whole thing. But if they have that scheme,
And how about the Shastroshati scheme?
Shastroshati covers some is up to 6 lakhs.
Okay.
But rest of the money patient has to give.
Second question is the refilling part.
Yes.
Who pays the money for that?
Refilling is not costly. These 2 ampoules of BACLOFEN injection, it will cost maximum 200 rupees.
Okay.
And OPD, they come 500 rupees.
Sure.
So refilling is not costly.
And just a last thing, in your experience, because we work together, we know the outcome. In your experience, how much of oral BACLOFEN does a patient need after the insertion of the pump?
If pump works, you don't need oral BACLOFEN. You don't need oral BACLOFEN. But sometimes pump, suddenly patient, what happens sometimes, the patient has to be aware that there will be alarm. They have to be notified that there has to be alarm. When there is a non-critical alarm, then they have to come for refilling. If they fail, then patient suddenly may develop severe spasticity, and that time you might need a oral BACLOFEN. So they have to keep some oral BACLOFEN in their home.
Thank you, Dr. Ghosh, for the lucid presentation.